make mistakes. I am human. Okay, thank you.
Thank you very much, Pablo. This was a great overview on vascular lesions, treatment with lasers. And now we'll go to the next speaker, Dr. Johan Snoeart, who is going to talk about photodynamic therapy and fractional laser. Another great experience in that field with many applications to be used.
Hello, good afternoon, everybody. No conflict of interest. I'm having a talk about photodynamic therapy, and this is a field I was starting with in 2012, so my experience goes back to more than a decade. And this is a field for skin cancer treatments where the use of laser is extremely helpful. So why did we start this? What is it, and when can it be used? So let's start with why. So in our country, in Belgium, we have a large population that has been exposed excessively to UV light during the 60s, 70s, and 80s without sun protection. And most of these patients have multiple lesions, and they try to find a patient-friendly treatment and minimal scarring after the procedure. What is happening in the cancer registration in our country is, you see here the blue line, that's an old slide, it's a couple of years ago, and you see that the blue line already crossed the numbers of breast cancer, the new incidence of breast cancer, and this is exclusive of basal cell carcinoma. The same we saw in the Netherlands, it's the country next to us. And this is a more recent slide from the Belgian Cancer Registry, and the numbers are still increasing. And what is more, you see an ever-increasing number for the males. So the females are flattening down a little bit, the curve, and for the males it's still rising. What we also learned from this pathology registry is that the elderly population is highly affected in this respect. And particularly something about Belgium, we have three areas. We have the northern part, we have the central Brussels area, and we have the French part. And these figures are quite different. So what we see in the northern part is the yellow line is a high increase. In the southern part, it's much less. I don't have an explanation for that. And in Brussels, the Brussels area has the highest concentration of dermatologists in Belgium per square kilometer. We don't see any rise. So this is something very special. Maybe it has something to do with the demographic evolution in Brussels. So this is a projection of the BCC that was counted some years ago. They do not count it anymore, too many of them. And this is the prediction for the future. So what they saw was quite an increase in number of new diagnoses with this time interval of 12 years. And here are the results of what we saw in our practice, as a practice with two dermatologists, me, myself, and my daughter. And we tried to register all the cases we could document and treat. And the increase is quite immense, especially for BCC and Bowen's disease, but also for squamous cell carcinoma and melanoma. And I think one of the reasons for that is that in this population where you have a lot of BCC and Bowen's disease, you also have a very high incidence of melanoma and squamous cell carcinoma. So at one point an investigation was done, and we looked at 100 files picked at random from this large group of patients. And we had in this particular group 10%, an incidence of 1 in 10 for melanoma and 1 in 3.5 for squamous cell carcinoma. So this is a special population. When you start with these treatments, you immediately get a high influx of this type of patients. And I will explain you later why. So we had about 1,600 patients in this period of 12 years with BCC and a little bit more than 1,000 with Bowen's disease. If you look at these patients, they have numerous lesions. The number of lesions that they have in the course of the years is quite high. So we looked at our patients and we saw that a lot of patients had more than 20, 30 and even 50 BCCs, and one patient reached the 88 documented BCC. So we need a treatment for these patients and we cannot excise everything. Before we start a photodynamic treatment, we always do a shave biopsy because the diagnosis is not always straightforward, especially in smaller lesions. And removing a part of the tumor is also part of the treatment, so it gives us better access to the cells that have to be treated with PDT. What is it? Well, it's not so new. I found in the literature a study of 1903 in Germany, in München, where they already worked with photosensitizer and light, also for BCC and condyloma. But the next publication was from the United States, where it was used as a treatment for different malignant tumors, not only for the skin. But the really most important publication was this one from Mariette Heddesdahl in cooperation with Rox Anderson in Boston. And they started a whole series of studies to show that this treatment modality, this laser-assisted photodynamic therapy, is quite useful. So if you look, this is my left forearm, if you look at what the laser does, it makes very sharp, delineated holes in your skin. And these are parameters I don't use on patients, they are too high, but they are for the purpose of showing what is happening here. But what is also amazing is that in less than 2 days, almost everything is closed again. So you have a very short window of opportunity to apply the drug and to have the effect of the treatment. And probably that's also one of the reasons why you hardly ever see any infection after this treatment. So how did we start in 2012? Well, we used these parameters, and since they work quite well, we stick to them, but I will refer to that later on. The security margin around the tumor is clinically not always very visible, and for that reason, dermoscopy is really a very interesting tool. So if you see here a lesion that has been treated with a fractional laser, you see that the margin is not really perfect, so you go a little bit further as for this lesion. And it's quite easy. If you do surgery and you have to take a margin, you immediately prolong the incision line. But with this is not the case. So you apply the cream, you wait for 3 hours under plastic occlusion, and then you irradiate. Before you irradiate, you can see the fluorescence with the blue light, which is always easy to see if everything is okay. And then you protect your patients. This was a patient that was treated on the back of the nose, and the amount of light is quite high and is quite uncomfortable. So protect the eyes as much as you can without covering, of course, the lesion. Sometimes we need multiple lamps. And then I come to my last paragraph. I show you some clinical results of this treatment. What is the potential of this treatment? And sometimes it's so amazingly good that you cannot find the original lesion anymore. This is a treatment of the scalp, also a difficult treatment to do surgery on. Upper lip with an elderly lady, and I cannot see anymore where the lesion actually was. Underlegs are often touched by Bowen's disease, especially in females because they are more exposed to UV light, and are also difficult to treat surgically with a lot of risk of complication. You don't see that with PDT. Here on the Achilles tendon, on the calf, also a difficult area for surgery. We follow up our patients, all of them, every year, and as soon as they have more than 10 BCCs, we follow them up every 6 months because otherwise we cannot keep up with them anymore. So they're developing too much lesions. Around the mouth is also an area where PDT can be extremely efficient and give a very nice result. And this was a little bit special case because the lady had a surgical excision for a basal cell carcinoma on the chest. And she didn't want any surgery anymore, and she left the lesion going on, and it became bigger, of course. And then I explained that maybe with this treatment modality we can do something, and the result was quite nice. But we needed more treatments than the 2 sessions that are classically used. After the treatment, sometimes you get some slight hyperpigmentation, but fortunately I'm working in an area where the fair skin types are more prevalent, and with time they usually disappear. What sometimes is left is a little scar from the shave biopsy. Here another example of this pigmentation, and it's almost gone 3 years later. Underlegs are a special area for Bowen's disease and basal cell carcinoma because they are painful during the treatment. I don't have a good explanation for that because this is an area that often needs local anesthesia prior to the elimination. I usually inject bupivacaine, 1 cc or 1.5 cc is enough, and without an epinephrine, of course, because we need the oxygen for the treatment. Usually on the underlegs, you also have a more brisk inflammatory reaction to the treatment, but it heals always quite well and amazingly fast. So these are the results. If I look back to the patients I have treated for the last 12 years, and the failure rate here was defined as not or incomplete results after 2 sessions. And I think I'm around, this is probably a little bit too optimistic because the treatments are ongoing, but the percentage of result is quite high compared to surgery. For Bowen's disease, it's even much better. And then if we want to ventilate to the areas that have been treated, you see that the nose is on top of the areas that is much more difficult to treat and has more failures than the rest of the body. The face is also a little bit higher, the rest of the body, so the trunk and the limbs are usually quite well and very few failures. That is for more than 3,600 lesions. So what are the pros? I think it's extremely patient-friendly, and because it's so patient-friendly, you will attract a lot of patients if you do these treatments, if you offer these treatments, because GPs, plastic surgeons, and other colleagues tend to know this, that there is a treatment modality where you can make disappear a skin lesion without leaving any trace. It's usually well tolerated. There can be some pain, and this can be managed quite easily in most cases, except for the legs. Sometimes it's necessary to anesthetize. It has a low risk, as I mentioned. It's highly selective, and I think this selectivity is very important. If you select only the tumor cells and the healthy cells remain intact, you get a rapid replacement of the cells that are killed by the treatment. It's quite efficient, I'll show you, and you can treat many lesions in the same sessions. And the downtime probably is, in all cases, much lower than with surgery. and less scarring I showed you with the clinical pictures. But there are some cons. It's time-consuming. It takes 2 sessions for each treatment. It's, you need some equipment. You need also a photosensitizer, which is not very cheap, and you need space for that. Some areas are more difficult, especially the nose. And for the difficult cases, infiltrating and sclerotariform BCCs, the Mohs surgery is still necessary. So sometimes I get referrals from Mohs surgeons who say that, or send patients to treat additional lesions if they have treated the difficult ones. The Bowen's disease can, in exceptional cases, be extremely resistant. I have a couple of them. I don't have pictures of them, but when we combine them with other treatments, it often works better. And we need, of course, better technology to predict when we are going to be successful, especially on the nose. And I think here is a place for this new LC-OCT technology to see how the tumor is behaving inside of the tissue. Some countries don't cover this by the insurance, which is also a problem, but some patients prefer a treatment without scar and paying out of the pocket than wait for reimbursement. What about actinic keratosis? In the beginning I was a little bit reluctant because these patients suffered more from pain than BCC and Bowen's disease, so I treated only a couple of selected cases. And especially the extensive ones were quite difficult. And I changed my view on this after I saw this patient who had already 6 squamous cell carcinoma excised, and he was really fed up with this surgery, but he has a lot of damage and hypertrophic and hyperkeratotic actinic keratosis. And I proposed him to do a treatment in a little bit different way with reducing the incubation time and reducing the density. So this was the result after the treatment, 2 days later, quite an extensive reaction. And this is not an ideal picture, but you can see that there is quite some improvement yet. He needs another session, of course, but he was quite happy, and I hope I can prevent with this treatment for him having more additional SCCs. And learning from this case, we treat now a lot of patients with male patients with a bald scalp, or even with a scalp that is balding and there is still some hair. That's not a problem. You can treat a lot of lesions in one session, and in many cases the patients are quite free from actinic keratosis for about a year. We all know that actinic keratosis is a disease that continues to recur and has to be treated on a continuous basis. So here are the parameters for BCC and Bowen. I already explained. We keep to them, we stick to them. But for a case, we lower the density and also the incubation time. So that was it. Thank you.
Thank you, Johan. Excellent talk. And now we are going to introduce Professor Badawi. All of you know him. He's the president of the European Society of Laser Dermatology, and he has published many books and many talks all around the world and courses. So Professor Badawi is going to talk about challenges in laser and energy-based practice.
Thank you, Pablo. Actually, in the field of lasers, which we have been working for many years, till now, even the basic applications, we are meeting some challenges on a daily basis. So I'd like to start with one of the oldest laser applications, which is laser-assist hair reduction. The principle of using the lasers to kill the hair or affect the hair is a genius one. It is a magical one from my point of view, because we are getting a light, a laser, which is supposed to be absorbed by melanin. And this melanin, which is present in the hair follicle, is supposed to convert the light into heat. And then this heat is supposed to damage the stem cells. This is a selective photothermolysis. This is what we think. This is what we built our assumptions on. So we started 30 years ago with what's called laser-assisted hair removal. And then this started with the key-switched Nd:YAG with carbon suspension. And then after some times, the FDA, who provided that approval for a key-switched laser system, they realized that there is nothing called permanent hair removal. It's called permanent hair reduction. So they changed the name from permanent hair removal into permanent hair reduction. And then after a while, they discovered that this key-switched Nd:YAG is giving a temporary remission of the hair growth. It doesn't even cause hair reduction. And then they started to go to the ruby laser and then the alexandrite laser and other types of lasers. The principle was that we are trying to kill and affect the stem cells when we are generating heat. Here there are two important questions. Number one, are we really killing the stem cells? And if you are really killing the stem cells, why it is permanent hair reduction, not permanent hair removal? And we'll discuss about that. But the other challenge, which will come with the slides, how come that we are using a laser beam, a light beam, which is targeting the melanin, and we use a certain wavelength, a certain fluence, a certain pulse duration, aim it towards the skin, which is sometimes tanned, sometimes dark, and then this laser beam is supposed to do nothing at the level of the epidermis and then go deeper and hit the melanin in the hair follicle and damage the hair follicle. This is like magic. It's the same parameters, but on the melanin in the epidermis, it has no impact or minimal impact, and then it has the full impact or a maximal impact on the hair follicle. This is something which we really need to think a little bit deeper in order to see how we are getting that. But let us answer the question of the stem cells. Are we really damaging the follicular stem cells? And this was a study published in 2006, which is about 20 years ago, about the effects of laser-mediated hair removal on immunohistochemical staining properties of hair follicles. And the immunohistochemical staining of the hair follicles remained relatively unchanged after laser irradiation, where this is actually amazing, because if we are not really killing the stem cells, then how and why we are getting reduction? Are we weakening those stem cells? For patients who are always complaining that I'm paying money and I'm still getting hair, certain areas of the body will respond much better. Lower legs in females are getting much better response than the face. For the face, they need to understand that this is an ongoing process and they have to do maintenance, and this is how it is. And sometimes when the patients are complaining that I don't want to see hair again, I tell them, actually, you are lucky that we are not that successful. If you are really successful in damaging completely the stem cells for the hair follicles and we are not going to get hair again, I expect that the healing properties of the skin is going to be poor. If you are damaging all the stem cells in this area, what will happen to the healing? This is very important. The stem cells are really very important for the healing. But no studies showed that we are able to really damage the stem cells in the skin for laser-assisted hair reduction. So that's why you are getting permanent hair reduction. We expect that after certain number of sessions, maybe average 5 to 7 sessions, we'll have reduction in the rate of hair growth, in the number of hairs, in the thickness of the hair. But then in certain body areas like the face and neck, maintenance is required, maybe 3-4 times a year. Clinics which are letting this to go with the technicians, with the nurses, without proper medical supervision, what happens today? They offer very low-priced total hair removal, maybe $100 or some countries $50, and then the patients are coming for laser shaving every month. It is not reduction. They are coming as if they are doing sweet. So this is not laser-assisted hair reduction. This is not based on science. In order to get proper reduction, we need to get a decent reduction, 70–80%, and then yes, in certain body areas, maintenance is required 2 or 3 times per year. This is what we expect. Now, the other challenge, especially in darker skin types, and here I'd like to stop for a second, because getting paradoxical hair growth is mainly limited or linked to the darker skin types. In the late 90s, when we used to attend conferences in the West, And we're telling our experienced speakers at that time, we're just starting the laser practice, that we get this paradoxical growth. Sometimes we try to get hair reduction, but the hair increases. They were saying, we are not seeing anything like that. You are just imagining. And why this was the case? Because when we are dealing with fur skin, with dark hair, it is easy. It's a piece of cake. We are going to hit the hair. When it's thick, we'll have less fluence, short pulse duration, and then when the hair is becoming thinner, we are just simply increasing the fluence, reducing the pulse duration, everyone is happy. But when we are dealing with dark skin, we cannot do that. We cannot just increase the fluence and reduce the pulse duration, otherwise I'm going to target the epidermal membrane as well before targeting the hair. So I'm limited. At that time, I'm conservative with using the appropriate high fluence or the shorter pulse duration. And in this case, instead of doing selective photothermolysis, we are getting another laser tissue interaction called photobiostimulation. So I'm stimulating the hair growth, and we start to get paradoxical hair growth. So this is more linked in darker skin types, and that's why they were not believing us when we are saying that we are seeing this. So how we are getting paradoxical hair growth, there are two main scenarios for that, and we have to differentiate between those two. Either we treat an area, and then we get good reduction in this area, but then the hair will start to grow in the surrounding area. So I treat the chin, it responds, we get hair reduction, but then in the neck we start to see hair which was not there. So it happens in untreated area in close proximity to the treated area. Or we treat an area, and this area had vellus hair, and then we start to see that this vellus hair becomes more coarse hair. So in this first scenario, cooling. I treated an area, it responded well, so this means that my parameters are correct. I got the result I want, but the heat diffused to the surrounding area, and I started to see photobiostimulation in the area, and that's why it's important to pay attention how I am cooling. If I'm cooling with cryogen or contact cooling, then it's very limited to the laser pulses. But if I'm using cold air, this is bulk cooling. It's cooling the skin before, during, and after the laser pulses. So the incidence is going to be a little bit less. But my parameters are okay. I just need to pay attention to the cooling in the surrounding area, and that's why if my system does not have this cold air cooling, then I ask the patient after the session to stay in the waiting area for 10 minutes with some cold packs on the area I treated and the surrounding area. The other area, or the other option, when I'm using the laser and this particular area shows more hair growth, then definitely it is something wrong with my parameters. No other options. Either I'm using too conservative fluence, too long pulse duration where the hair is becoming thinner, or a long wavelength which is not going to be well absorbed with the finer hair. So I'm going to get biostimulation instead of selective photothermolysis. I need to revise again the parameters and start to use the proper parameters to get rid of the problem. Of course, in both scenarios, if there is underlying pathology, the incidence is going to be higher. And that's why the number one step is to evaluate the patient medically to see if there is any underlying pathology. Medical treatment is required to be going hand in hand with the laser therapy. Otherwise, we'll get higher incidence of paradoxical hair growth. This is an example of a patient who had fine hair. Usually this is going to happen in darker skin population with fine hair. And then after a few sessions, we started to see the paradoxical hair growth. Another patient, less hair after the treatments, we are getting terminal hair growth stimulation within and around the photoepilated area after 5 sessions of lasers. Again, this is another problem happening because non-qualified practitioners are working, technicians, nurses who are not well trained, or this is not medically supervised. The physician, even if it's there, they are going to write the parameters in the first session. And then every time the patient comes back, they are using the same parameters, which is wrong, because with subsequent sessions, the hair is becoming thinner, finer, where we need to change the parameters according to the changing situation. We need to shorten the pulse duration, we need to increase the fluence. If this is not happening, then at a certain point, we'll get paradoxical hair growth. So the causes of that might be suboptimal fluence, long pulse duration in cases of fine hair, long wavelength in fine hair. If I'm using a diode laser or Nd:YAG laser while the hair is fine, then it is not going to target the fine hair, and we might get paradoxical hair growth. With the diode laser, we have an issue because we cannot control each parameter independently. In the diode systems, if I reduce the pulse duration, the fluence will automatically go down. And if I increase the fluence, automatically the pulse duration will increase, where we need to do opposite things. For fine hair, we need to reduce the pulse duration, and we need to increase the fluence. So if I'm not able to do that, then this is a problem, and that's what happens sometimes with the diode laser systems. Fine hair with cryogen. If I have a system which is working with cryogen, the cryogen is going to be sprayed on the skin just before the laser pulse. And then the laser pulse is going to follow. This cryogen is causing fog. This fluid or cryogen material is causing a lot of scattering and reflection. So if the hair is thick, this is not an issue because there is significant absorption by the hair follicle. But when the hair is becoming thinner, the absorption is going to be less, and any loss of energy due to the reflection and the scattering is going to impair the laser tissue interaction and will get less effect, so photobiostimulation can happen. And that's why many people who are having the cryogen-based system, when the hair is fine, they stop. They don't go further. And of course, if there is any underlying pathology, this is something to be treated. This is a very interesting article, and I wanted to highlight because sometimes what we do as practitioners, I'm looking for a certain topic, so I open the PubMed, and then I see a paper like that, which is saying evaluation of long pulse Q-switched Nd:YAG laser for hair removal. And then the conclusion, I jump to the conclusion, and I find that the conclusion is saying the long pulse Q-switched Nd:YAG laser provides safe and effective means of hair removal, not even hair reduction. Number one, there is nothing called long pulse Q-switched laser. It is either long pulse or Q-switched, right? This is number one. Number two, if you are talking about Q-switched laser, it has never been proven that it causes laser-assisted hair reduction. Even, I mean, not hair removal, not even hair reduction. It's temporary recession of the hair growth, which is going to come back with the same count. So if someone is reading that article and then this conclusion, he might go tomorrow to buy a Q-switched laser and offer it for hair removal, and then we are failed. How many times did we buy lasers and machines with certain expectations, and then we are embarrassed in front of our patients because it doesn't deliver what it's supposed to do, right? So it's really very important to test the scientific content of any paper, not only the title and the conclusion, because sometimes you are going to realize that this is not going to happen. So this is fine hair in dark skin where the long pulse lasers might not work, and this is a patient who is very prone to get paradoxical hair growth, but using a Q-switched Nd:YAG with low intensity might save the problem, like this. Also like this. It can work on thick hair. The remission is going to be a bit longer, but still, we are not going to expect reduction of the hair, except in very rare cases, which I wouldn't promise the patient to have. What are the parameters to be used when we are having a Q-switched Nd:YAG for hair shaving? I call it hair shaving. It bleaches the hair, and then the hair is going to fall off within 7 to 14 days, and then the hair is going to come back with the same count. So we are using the Q-switched 1064, 6 millimeter, 2.5 to 3 joule per centimeter square. We do 5 to 10 hertz. No cooling is required. Painting till we see bleaching of the hair. And the benefits of this procedure is that it's associated with minimal pain, minimal side effects. It's very quick. We can work on any skin type. And one of the nicest things patients love is that no shaving is required. But the most important thing is to let the patient know that we don't expect reduction. Some of the patients will get reduction in certain body areas, but don't sell this because this is not guaranteed. Sometimes it will happen. In most of the cases, it's not going to happen, especially in the face and the neck. Another problem which happens sometimes with laser-assisted hair reduction is doing laser-assisted hair removal, and then the patient comes back after a few sessions telling you, doctor, after few sessions, I got white hair. It happens. What is the reason for that? Sometimes it's a pre-existing condition. So the patient had few white hairs among many black hairs. She didn't even pay attention to that. When we use the laser, it's going to affect the black hair, but the white hair is not having chromophore, so nothing will happen. So they keep being prominent alone after getting rid of the black hair. So they will start to see it. Or we can induce that. If you use insufficient fluence in predisposed patient. Who is the predisposed patient? Someone who is 45, 50 years, they still have black hair, but the hair is about to turn into white. If I use conservative fluence or longer pulse duration than required, I can hit and damage the follicular melanin, but without enough heat to damage the follicle itself. So in this case, I can turn a black hair into white hair in the susceptible patients. So if you are treating someone who is in the late 40s, please don't use conservative fluents. Protect the skin by using good cooling instead of lowering the fluents or increasing the pulse duration. And this is a typical patient who came after a few sessions and said, "Doctor, after your sessions, I got so many white hairs." Luckily, we had the photo of before. And then we started to show her, actually, your white hairs were there, but you didn't see them because you were seeing the black hairs. Once we got rid of the black hairs, then the white hair started to stand alone. And the only solution till now for the white hair is electrolysis. All the trials with laser for white hair didn't work. Don't sell that the Nd:YAG laser will work on white hair because it will attack the vascular supply of the hair follicle. Even if this is going to happen, you are lucky, but this is not something we sell. So this is regarding the leukotrichia or the white hair after the laser. Post-laser folliculitis. Every couple of weeks, I get a phone call from one of the colleagues, "Dr. Ashraf, we don't know what to do. After hair removal, the patient is getting severe folliculitis, and we keep using antibiotics, it doesn't improve." Actually, this is not an infection. This is a foreign body reaction. With the laser, we are changing the protein of the hair follicle, and some people are having an immune reaction, which is a bit aggressive, so you'll get allergy. So in this case, the best scenario is just to reassure the patient that with subsequent sessions, when the hair follicles are becoming thinner, the reaction is going to be milder. The advice I would give is that 2 days before the laser session on the treated area, apply weak steroid 2 times per day for 2 days, and then 2 days after the session. This is going to be much less. Antibiotics has no role. This is a foreign body reaction just like this one. Pseudofolliculitis Barbie, it is the same. So when we have this condition, sometimes we have males who are having pseudofolliculitis Barbie, and before the era of the laser, we were telling them you have one of 2 options. Either to shave every day, and of course, once we say that, they open their mouths and they think we are crazy. We are telling you we have this problem from shaving, so you want me to shave more? Yes, because if you shave more frequently, the hair is not going to have the chance to grow in order to grow back to the skin. So we are never going to get that. So shave every day, or just leave your beard. You are going to have that reaction temporarily, and then the hair is going to get out of the skin, and the problem will disappear. But now with the era of the laser, we have a third option where we are able to use laser-assisted hair reduction. But if the patient came like this, we don't like to treat inflamed skin. So I would tell the patient, I'll send him home, tell him, leave the beard, don't shave for 2 weeks, and then everything is going to calm down. Shave your beard after 2 weeks and come the next day. So the skin is going to be calm, and then I use the laser. And when I use the laser, I need to use conservative fluences because I'm dealing with dark skin. I'm dealing with very thick hair. So in this case, I'm going to be using the Nd:YAG. Diode even sometimes in that dark skin, if skin type 5 or 6, might be not safe. So I would use the 1064. Fluence should be very low because the hair is thick. So even 20 or 25 joule per centimeter square is going to be enough. There is no point of going to 40 in this condition. It's going to be too painful without any additional benefit. So I would use something very conservative, and I'm going to see the hair charring or ejected from the skin. So this is a good endpoint which I'm going to follow, 20 or 25 joules. And then when the hair is becoming thinner in the subsequent sessions, I'm going to reduce the fluence. What about the pulse duration? Dark skin, very thick hair, so I need to use very long pulse duration, 40 milliseconds or 50 milliseconds. Again, when the hair is becoming thinner in few sessions, I can go down to 30 or 35 and so on. And the spot size, there is no point of using very large spot size because if I use large spot size with the Nd:YAG, the penetration depth is going to be very high and the pain is going to be too much. And the hair follicles here are not very deep. So I would use 7 millimeter, 8 millimeter, 9 millimeter, something like that, not more than that. Otherwise, it's going to be much painful if I'm using larger spot size. It's a small area, it doesn't need a larger spot size. So this is how we think and we analyze the problem. The endpoint will be the hair. You need the hair to be charred or ejected or depending on the pulse duration, immediately with the pulses. And that's why I don't like to shave immediately before the laser. I need to see the laser tissue interaction. So I need to see an impact on the hair. If it doesn't happen, then it means that you are using too low fluence. You need to increase a little bit. Pigmented lesions and tattoos, I think one of the most challenging applications to treat with laser is melasma. And for that, if we open the literature, we are going to see so many publications about using the laser for melasma, including 1 or 2 studies I published, so it works. However, before I choose the laser to treat and improve melasma, I need to sit down with the patient and discuss realistically what to expect. With melasma, we know that this is a chronic relapsing condition. And we tell the patient, we educate the patient that once melasma, always melasma. So there is no cure. And we can improve the melasma either by using topical bleaching agent after improving the epidermal barrier function, using sunscreens, and it might give the same results of the laser. With the laser, it's a more expensive procedure. In both ways, it's going to relapse, so we need to discuss with the patients. Patients who have melasma have used everything. So the laser might be an option for them, but it's important to let them know that we can improve the condition, but it's going to come back. I always explain to them, melasma is just like the diabetes or hypertension. Did you ever hear about someone who is taking the medication for hypertension for 1 month and stop it? This is a treatment for life. The same for diabetes, the same for melasma. As long as the patient know what to expect and we understand what we are going to do, then everyone is going to be happy. In the old days, the Q-switched lasers were used to treat melasma, but we had many cases of paradoxical darkening of the pigmentation. So now they have different protocols with low intensity, with laser toning in order to improve the melasma, but it's going to come back. Sometimes fractional lasers with transcutaneous delivery of bleaching agents are going to work. It's important to understand our tools, understand the pathology we are dealing with so that we are able to educate the patient what to expect out of the treatment. Becker's nevus. Becker's nevus is another challenge. This is a compound nevus, partially in the epidermis, partially in the dermis. And there are many protocols to treat it, whether it's Q-switched lasers or fractional lasers. And again, there are publications for successful treatment of Becker's nevus. From my point of view, I try to advise the patient not to treat. It's a large lesion. It is compound. The outcome in many cases is very, very heterogeneous. Some areas will respond beautifully. Some areas will have darkening, and some areas will not change. So at the end, we are removing a big nevus and leaving heterogeneous pigmentation. So I try always to convince the patient, don't worry about it, it's never going to turn into cancer. Try to live with it. If they insist, what I do? I work on a small segment of it, 10 centimeters square. And in this segment, I'm going to use Q-switched lasers, but I'm going to do double layer treatment. I use the Q-switched Nd:YAG to attack the dermal component of the nevus, followed by the 532 in order to do the epidermal component of the nevus. And sometimes I add on top of that Q-switched fractional laser in order to try to improve the skin and decrease the recurrence. And then we continue to treat the same area. Every time the patient comes after 6 to 8 weeks, we treat the same area till we get to the final result of this area and tell them, this is what we are able to do. If you are happy, we move to another area. The importance of this is that if you are treating the whole lesion, even with the protocol I'm telling you, the patient is paying a lot. And the more they pay, the higher expectations they have. And sometimes we really get darkening. So the patient is going to be frustrated. If you are working on a small area with limited price for the session, then he understands that it's not a matter of getting money. We want to get satisfactory outcome for him and for us. So this is a much better approach. Cosmetic tattoos, lip line tattoos and eyebrow tattoos, one of the biggest challenges is that with those inks, whatever experience we have, we cannot predict how the ink or the tattoo is going to respond. So sometimes we are treating the lip line and we end up with a totally different color, which is more ugly than the original tattoo. So it's always advisable to do a couple of pulses as test and wait for 8 weeks to evaluate, because the end result is not going to be achieved before 8 weeks for the phagocytosis to happen. So this is very important. I never treat the whole eyebrow or a whole lip before I do 2 pulses and see how it's going to react. Now, we have many options in order to treat acne scars and post-inflammatory hyperpigmentation, and one of the indications of the picosecond lasers, when they were introduced about 6-7 years ago, is to do rejuvenation. What happened? The machine prices were really sometimes $300,000. And those machines were supposed to be used for treatment of skin pigmentation and tattoos and marketed as the magical stick. Picosecond lasers, we are going to use 1 or 2 sessions and get rid of the pigmentation or the tattoo, which never happened because sometimes we are dealing with challenging pigmented lesions and challenging tattoos. So they started to extend the application to rejuvenation and other applications which might work because with fractional picosecond or nanosecond lasers, we are able to get fractional treatment with no heat, so there is no risk of hyperpigmentation. The healing is very quick. It's a good principle, but sometimes we have the same conditions where we need to think a little bit scientifically, which layer of the skin we need to improve. Do we need to tighten the skin? The patient coming here to complain of active acne, acne scars, post-inflammatory hyperpigmentation, large pores, some skin laxity. So using fractional laser is going to deal with only one problem, which is the scarring. It's going to stimulate new collagen formation. Is this what we need? Is this what will make the patient satisfied? Or is it better to have a rejuvenation plan in order to deal with the pathology existing in different layers of the skin? For this laser, I need to do some tightening. I need to stimulate the collagen, not only in the areas of the scars, but also on the whole skin because the patient has lost significant amount of collagen. We need to deal with the PIH. We need to deal with active acne. So I need a comprehensive treatment plan in order to improve the skin like this. And this is something which can be achieved by a combination of microneedling radiofrequency and microdermabrasion to improve the epidermal barrier function. It's just the logic, it's just the science. Where is the pathology, in which layer of the skin, and I need to understand my tools instead of running after what the companies are claiming in our field. With the picosecond laser, we need to invest at that time. Of course, now it's much less, but $300,000. With the combination of microdermabrasion system and microneedling frequency, we might spend $50,000. And this is the result. So it's not a matter of the machine, it's a matter of the way of thinking and building things together in order to tackle the different areas of pathology with the different tools we have in order to get the best outcome. So I think always analyzing what is the kind of pathology we would like to improve, and then understanding very well the different tools we have, whether it's injectables, energy-based devices, lasers, then we are able to utilize the right tool to handle and target the appropriate pathology for that tool. And with that, I would like to end my session by inviting you to join the European Society for Lasers and Energy-Based Devices. This is a non-profit organization, European organization working in the field of laser and energy-based devices. It does a lot of educational activities in the field of lasers and energy-based devices. One of the most successful activities is the teaching courses, which we conduct in one of the European university hospitals every 6 months. The next one is going to be in Bucharest, 13th and 14th of February. Usually it's over 2 days where we cover many topics in the field of laser and energy-based devices, and we have also practical hands-on session. So hopefully I would see few of you in that course. Thank you very much for your attention.
Thank you, Ashraf. And now we open the floor for questions.
Yes. Can you approach one of the mics for the question? There is a mic there. Yeah. You have a question?
Yeah, hi. Saqib Bashir from London. Thanks for all the talks. They were all amazing. I just wanted to ask about the laser-assisted PDT. How much do you think the treatment response is due to the ALA and the free radical formation, or how much do you think of the treatment response is due to an immune response created by both the trauma of the laser and the light therapy? Thank you.
Very interesting question. There is a recent study of the group of Copenhagen which showed a high influx of immunocompetent cells after the laser pulse. So it's my opinion that the laser pulse does not only open the skin, but causes the immune system to react vigorously. So there is a lot of cells present, killing cells, T cells present to clean up what is happening after the impact of the light. So there's definitely a lot to study about that. It's not only opening. And I think that's one of the main reasons that laser is superior to other modalities of opening the skin, but has to be confirmed.
Thank you for interesting sessions. I want to ask Dr. Ashraf, please, the role of lasers, hair epilations, and those patients with hypertrichosis on minoxidil oral treatments.
Yeah, actually, two things, because I forgot to mention that. We started about maybe 6-7 years ago to hear a complaint of patients which we didn't hear before, which is the bromohydrosis and hyperhidrosis after axillary hair reduction. So people started to complain that after the hair reduction, they get bad smell of the bad odor of the sweating, or even excessive hyperhidrosis. So this is sometimes happening with the laser because we change the microbiome in the area. And the solution might be to do Botox injection in order to suppress the sweating. And in many cases, after some suppression, is going to resolve the issue. Now, if someone is taking minoxidil and they are undergoing laser-assisted hair reduction, we expect that as long as the exposure is there, the problem is going to be less optimally responsive to the laser. It is the same like if someone is having hormonal problems or hyperprolactinemia, then also the response is going to be suboptimal. So we just need to educate the patients that you might need more sessions, the response is going to be less, but we have to set the priorities. It's just like when we do injection and we tell the patient, you have to stop your anticoagulant. This is crazy. They are taking the anticoagulants to prevent having, clotting. So get bruises, but just tell the patient that you will get bruises because you are taking aspirin. The same, if they are taking the minoxidil because of a genuine reason, then you just tell them, we are going to do laser-assisted hair reduction, but the result is going to be suboptimal till you stop it.
I have a question concerning hair and one more concerning vessels. The first one concerning hair, you told us at the beginning of your presentation, you asked the question, why is there a better result on the legs than on the muscles, for example? And I didn't get an answer for that during the presentation.
Yeah, there are many factors which are affecting how different body parts will react to the laser-assisted hair reduction. One of them is the hormone-responsive hair follicles, which are going to respond in a different way than the non-hormonal areas. So that's why some body areas are not hormone responsive, and they respond better than the areas which are more responsive to the hormones. So that's why certain areas are going to be better responsive. The other thing is the anagen phase, how long it stays. When it is longer, then the response is better than if the anagen phase is shorter. And this is different from one body part to another body part.
And please, to this end point of the 1064, sometimes when I'm doing my laser removal with 1064, I'm not seeing the hair like burning away, but I've been told from the laser company that actually the energy is going to the root in that case, and I still have to consider that even without seeing an endpoint, I achieved my energy. So I was like perplexed. I need to see that the hair is away. Is it right that when treating with 1064, we don't have the same endpoint we have with 755?
Sometimes yes, because the Nd:YAG is less in absorption. Alexandrite is going to show a little bit more. Yeah. However, at the same time, if the hair is thick, you need to see something.
Yeah.
But I have a question for you.
Yeah.
How long have you been using the laser for hair reduction with the Nd:YAG? For how many years? 1 year?
Not that much. I used to use the 755.
Okay.
So this is where I have more experience, and I don't get in Germany a lot of dark skin type, so that's why I don't have enough experience with the dark skin type.
How long did you start to use the Nd:YAG for? 1 month, 2 months, 3 months?
It happens like once a year or twice a year, and my first patient I had was like 5 years ago.
Okay, and for that patient, you didn't see this change on the hair?
I
But
saw a change. It
you
was
said-
on the legs, yes.
Okay, so you need
But-
to see something.
But how can I know that I am on the right parameters?
You need to see some perifollicular edema or perifollicular erythema. This is a very good endpoint, at least. If you
Okay.
didn't see that, then usually it's going to be less. But let me also comment on what you said, because this is a misunderstanding. We always think that I have alexandrite and I have ND egg. The alexandrite I'm going to use in the dark skin, the alexandrite I'm going to use in the fair skin, and the ND egg in the dark skin. But actually, this is not true. If you have thick hair, thick dark hair, regardless of the skin type, please start with the ND egg. ND egg is going to be safe even if the patient came from the beach yesterday. Safe, because it's not going to interact with the epidermis. ND egg is deeper in
But
penetration.
I'm losing my NDAG impulses. I need my NDAG for vessels, for rejuvenation, and it's rather expensive using NDAG.
Yeah, but NDAG is very, very long-living laser. The NDAG cavity, laser cavity and rod was much, much longer than the alexandrite.
Okay.
So don't worry about that. But use the NDAG when the hair is thick. Once the hair is becoming thinner, if the skin is fair, go to the alexandrite. If the skin is dark, then use the NDAG with the right parameters. But NDAG in thick hair, it is the best. It is the best. You are going to be loving it because there will be no crust, no epidermal reaction. It is going to be, even because of the depth of penetration, the remission is going to be longer than with the alexandrite. Try that and you will love it.
Thank you.
You had a question for vascular?
Yeah, I don't want to monopolize. I have really respect when I see you treating the vessels on the temporal area, because I use also NDAG for the legs, and I experienced once a thrombose on the leg. Well, it happened just one time, and well, since I saw this complication, I can't trust myself going on sensitive areas like the temporal area. So what is your experience concerning such sensitive areas?
Okay, I thought the same at the beginning. I was a little bit afraid to do it, but after reading some papers, I started it, and I haven't seen any problem. I haven't using these settings, long pulses, spot size, let's say 3.5, and not too much energy with this endpoint. I haven't seen any complication, but normally I treat just one side, not both sides at the same time. Perhaps you can do that, but...
Actually, I have a publication about this periocular veins. And for the past 20 years, I treated more than 1,500 patients. There's no problem, because we have to understand that we are dealing with the superficial system of veins, not the deep system. And there are valves to prevent anything happening in the superficial system to go to the deep system. So deep venous thrombosis is not a risk of laser treatment. You are going to get thrombosis, yes, in the superficial, and it's going to be absorbed and going away. So this is not a concern. What happened in the leg veins, I don't know. If you use too high energy and you had ulcer or whatever, it might be from the wrong parameters used for the leg veins. Leg veins are more prone to get hyperpigmentation, hemosiderosis, than in the face. But usually it's not a problem at all. One of the rare problems happened to me maybe 3 or 4 times during this past 20 years is that I treat a vein and I tell the patient that you might get bruises, but bruises doesn't happen. And then she goes back home, everything is okay. 3 weeks later, she comes back with a bruises in a different area. So I treated the vein here, and then she comes with bruises in the upper eyelid and the lower eyelid, different area.
So it was a thrombose?
It was not thrombosis, it's just you are killing part of the network of veins. There is some blood which is trapped in an area, and then it degenerates.
Yeah.
So just reassure the patient, this is, you explain that, and you tell her it's going to go away in a few days, but this is not thrombosis. It's just leakage from air, blood which was trapped.
Okay, thank you.
We have time for one last question.
Sorry. Sorry, I have a question about tattoo removal. I have a patient with multicolor, yes, he's a Caucasian, with multicolor tattoo over arms, which contain red, yellow, green, and sky blue. So I have treated him once with quite good response over the red one, the green one as well, but the sky blue one seemed to have really less response, and also the endpoint very difficult to check on the endpoint. So I'm using, so the sky blue is 595, but the endpoint is not quite good. But the green one is quite good as well. So would like to ask whether I need to increase the fluence next time after 6 to 8 weeks, or try another wavelength.
Yeah, this wavelength is introduced in order to treat that color of tattoo. However, the problem is that those hand pieces are having very low energy and very low power. And that's why sometimes it's not going to be very successful. You need definitely to increase the fluence. And my advice is to add on top of the Q-switched laser, fractional Q-switched, even if it is Nd:YAG, because in this case, fractional 1064, because in this case you are removing part of the ink and leaving some opening in the skin in order to get rid of the ink through the skin, instead of depending only on the lymphatic drainage to get rid of those small fragments. So this is what you might try to do.
Actually, I'm using a Pico laser for the tattoo removal, but is it, I would need to change some Q-switch?
The picosecond laser, I mean, we have again to understand a little bit more. Picosecond lasers are going to be excellent when the concentration of the ink or the melanin is low. But when we have good concentration of the ink or the melanin, the Q-switched laser will do the same. It's going to target the large particles. When the particles are less in size, then the Pico is going to have the role. So in both, if you do fractional Q-switched or fractional Pico, this is going to open the skin, and part of this pigment is going to be sloughed through the skin.
I see. Okay. Thank you.
One last question. Can you approach the mic? Yes? Can you approach the mic?
I need to know the parameters for the periocular vein treated with Nd:YAG.
Yeah. Normally we use spot size 3-5 millimeters, pulse duration around 20-40 milliseconds on long pulse, and fluence depending on, I would say, from 90 to 140, something like that, depending on a little bit on the size of the vessel. On the, you can. I show you a video of the proper endpoint. I don't know. Okay.
So thank you very much for your attention, staying till the end of the day and the session. And I would like to thank the speakers for their great talks, and have a successful meeting. Thank you very much.